So the plan is that we have to get 8 people together so that we can have a discussion. And they were going to come in here and break down this whole stage and set up seating across here. And I'd like to vote for a different way of doing that. There's easily 8 chairs sitting right out here in front that we can gather around. We can pass the microphone around, and I think we can just get that going quickly so that we can get through the last time here so that you can get home. But I don't want you to miss this part because I think it's going to be important ways to tie up some loose ends and get some opinions about how this whole 2-day event is going to help to change the paradigm for managing chronic pain and substance use. So could the 8 panelists come up and grab a chair and we'll grab microphones? Okay, let's go ahead and do this. We have had a fire hose of information shot at us over the last couple of days. And what we've got here is the United Brain Trust of the best pain people and substance use people in the country, other than the rest of you that are sitting in the audience and those people that were unlucky enough to not to be here over the last couple of days. But we've heard some amazing things, and I'd like to have you go through in the panel, no specific order, but just volunteer some things that you may have actually gained from this whole event that you didn't have when you were coming in here.
I guess I'm holding the mic, so I'll go first. I think what I was struck by is the number of different functional areas of treatment that are involved in this room. I mean, so people from peer support to running an institution to paying for care to delivering care directly, actually being on the same page and knowing that current state is not good. So it really felt like everybody really did want to move toward the right answer for patients. And it wasn't a bitching session, which is what a lot of these turn into. There were people really asking for what are the next steps and having their own bright spots of work that they do. I mean, some of the stuff that I've heard from people here is amazing what they do, and I think they don't understand how special the work is that they do in the places that they do it. So I thought that was what I gained, is just hope, actually, that this is a fixable problem.
Yeah, I thought this was really fantastic. For myself, what I found interesting was even just there was a number of things that I learned, especially on the trauma side, in which I had an understanding of it, but seeing the depth and the other issues in the way to manage things differently was really fantastic. And it really highlights, it's so wonderful to be in a group of people who understand that the mind and the body are not separate, and that all of this connects, and that it really is a larger issue. And coming here and hearing all the different solutions actually gave me stuff that I can take back as well.
I think the term for summit was a great term. It's really a consortium of different ideas, which is really the focus of treating chronic pain and how it relates to substance use disorder. And from my school of thought, being the multidisciplinary sport that it is, what I liked was how it was dovetailed to really think of then how do we value the work, and then how potentially we could pay for it. And I think that's probably one of the most innovative aspects for me from this consortium of all the intelligentsia in the audience and in the podium. And there's been a struggle in pain management where none of our national societies have been able to reconcile a consorted nutrition program for pain patients, functional metrics for pain patients that everybody can agree on, or even all the metrics associated with the multidisciplinary care model to treat pain patients, but yet it was conversed and discussed here. And not only that, in a brief period of time, and then a thought process with potential ideas on how to actually get reimbursed for it. So I think that was great.
I think I would want to say that what we learned here was that the treatment of pain does not necessarily equal a pain pill. And that's why we maybe got into this mess, is that we tried to treat pain with a pill. And I don't remember who brought that up yesterday morning, but and that's what it became equated to with our patients, that that if you have any pain complaint, you can just take this pain pill and it'll go away. And what we saw yesterday and today is that's not necessarily the case. And trauma therapy is pain treatment. Teaching about nutrition is pain treatment. Getting your patient to exercise is pain treatment. Getting them to address their behavioral health needs is pain treatment. And so getting not only clinicians to understand that, but patients and the public as well, so that when the expectation goes into the doctor's office, mainly at the primary care, because that's where most of pain care takes place, is that the expectation does not become a pain pill. That if you don't walk out of the office saying the doctor didn't do anything for me because they didn't give me a pain pill. Instead, they embrace some of these alternative treatment models.
So I think I'm amazed that a health plan put this together and that we had such a great turnout. That to me is an echo of hope. And you know, we heard a great sort of recitation of the different pieces of the puzzle. It's now on the floor, and it's time to get the right people. I would encourage this plan, move forward to the next step, get the right people in the room to start putting the puzzle together. And we know how to collect the data and do the analytics, but put together the treatment programs, the treatment paradigms, and run them and see how we're doing. Keep this going forward.
So the thing that strikes me most about this is that it's replicable. You could do this. We could do this not just in Texas, but all over the country. Can bring providers and experts together, can learn from each other. And there's very, very few people, I mean, maybe apart from Manu, who know all parts of the elephant. So bringing us together to be able to, you know, do this essentially is something that completely could transform the way that we're learning about this issue.
I think this is, just picking up on what you said, this is probably the most, or maybe even the only, very optimistic conference about pain. Maybe that's an oxymoron, but I am leaving with a great sense of optimism for the first time. We have a unique confluence of opportunity right now. There's public awareness, there's legislative awareness, there's a clear model for how to do it, there's the expertise. It's not like we don't know what needs to be done. We have the technology platforms to make it happen, and now we have a health plan engagement trying to help figure out how to fund it. So I don't think any of us should leave today without thinking that the time is now to actually do this and make it happen.
Yeah, you know, Dan, I think you need to take over the presidency of the AAPM or something. You know, because by far, I pretty much stopped going to many of these meetings because it's the same garbage being repeated. But usually the theme is, I did so many of these, and my patients do fantastically well, so I'm the best. But the difference in this conference was, it was very, very, what do we need to do? So it was based on the needs of what needs to be done for the patient and the larger population, and how do we need it? How do we do it? So it was more of a concerted problem-solving effort rather than people kind of tooting their horns. So I think that keeping focused on the need of the problem is how this truly has been a very, very unique experience for me, and I wasn't expecting it. So congratulations, excellent.
How much of this is ever going to boil up to the top in APS, ASAM, AAP, you know, all the other organizations that are out there? How far ahead of the curve are we sitting in this room compared to where the leadership is that should be talking this way?
So I'll give one perspective from the American Society of Addiction Medicine. I've been pretty involved in them in the last really 5 to 7 years. And I would say within that organization, it's at a tipping point where there are enough of us that are based in data science and math and pragmatism that it is rapidly and consistently displacing those that are from the old guard and unwilling to change and progress. Those that love the way that they do it and have made money from it have stood in the way a long time of what progression needs to be for the whole in the population health aspect. And we are just burying them in data science and math on a consistent basis to the point where their voice is getting smaller and smaller. And it's not just a matter of we're in there, but we're leading things. We're in charge of committees. We're writing new policies. We're engaging at the federal legislative level and the local state level. We're writing guidelines and pathways. So I know that that's also happening in American College of Emergency Physicians, as well as the AAP. I mean, there are things that are happening, and we are at the tipping point in all of these national societies to where the BS rhetoric is now going to get pushed out with science, data, and math for those of us who've paid really close attention to it and don't have our hand in the pharma bag. And I think now that we're pushing past this, and that generation of people who really grew with both pharma and device and that not being attached to it are coming up with new pathways that are based in just the science, not just the economic science.
So on the American Psychiatric Association side, it's similar. I sit on the APA Innovations Committee along with Sosamolu, who was here earlier, and a few others. And but one of the challenges we face is that it's not just the old guard leadership-wise, because I think we've solved for that largely on the APA side. It's the membership, the members themselves, which drive a lot of these organizations' priorities. How does the value of something like this get propagated back to the members so that they can see, yes, we demand this from the leadership, and we want the resources of these organizations to be applied against solving problems with data, science, predictive analytics, and multiple sides of the coins?
The leadership of those organizations have a very hard time taking unilateral action for that very reason, because you rely on membership. Those are membership-driven organizations that you're talking about. So it's very hard to get disruptive change coming from leadership that their jobs are paid by the dues. On the other hand, just as an aside, I'm going to a conference in the state of Arizona set up by the governor's office and heavily influenced by the state Medicaid program. And it's going to look somewhat like this. Yeah, I mean, I hope so. I hope so. I'll tell you either thumbs down or thumbs up. But this sort of conference is happening, not just here, but it's happening, which I can't believe it, in my state of Arizona. And that there's a cadre of very smart, data-driven analytic people in health and human services that are really pushing that forward. And I wish this whole panel could show up, but you're probably taken.
Yeah, and they're right on target. And one of the things that Corey talked about was in the data-driven science of it. And I know again with ASAM, we're now adding core competencies for pain within the addiction medicine community to reestablish what are those core competencies. But I think in one of the great things, like we've already said, is the fact that Superior, that a health plan came and brought this all together to come up with ideas is really groundbreaking and really important. But I think the next step, the way to get the endorsement of all of the groups is to come up with a model that makes financial sense as well. Because if you can prove the economics of it, well, which is where we want to go with value-based care. So if you can say, hey, look, we all got together and we did a couple pilots and we proved that this not only does it save money and providers are able to do well with it and the patients get better, which is really our goal, is to have everybody win, then I think the ability to gain acceptance and momentum and the groundswell that would come with it is vital, because if they're not aligned from an economic sense, it's harder to get everyone together.
The healthy dose of optimism is palpable. I'll mention when we, at UC Davis, when we had a summit to develop pain competencies, I think this is the astonishing aspect, is that only happened a couple of years ago. And the field really didn't have competencies, at least that had been spoken about, but formalized. When we presented the work at the International Association for the Study of Pain in Yokohama, oddly, the commentary was, why do we need this? So what I would tell you is that the unfortunate aspect of the societies is that folks are very the thought process is very focused on specific aspects of the discipline, but the 50,000-foot view often gets lost. And so I think you have poignantly pointed it out. And so I'm hopeful that programs like this continue.
Great.
You know, I'm not as optimistic about as Corey is, that you can teach, old dogs new tricks. My own feeling is that the push has to come from a different side, and that side will be physicians, patients, payers, but mostly led by HHSE, CMS, and all of those organizations. Eventually, the reality is that pain is a lucrative business. You know, there are billions of dollars being made by the current chaos. So we can't expect people who have the money already, who have the ear of people who can at least make short-term or intermediate-term changes, to just give it up and walk away. It's going to be a brutal fight, and it's probably going to take 10 years. So even to the point that we have gotten here, although I haven't been in the business for that long, in 2006, 2007, I thought, in a few more years, you can see all the chaos, you can see all the money that's being wasted. Things are going to change. We have the space has been painfully slow. So it eventually, the beauty about this country is eventually, people will follow the green. And so it'll have to be led by insurance companies, but really it'll be led by CMS and HHSE and all of those organizations. Once the incentives get changed, that is when all of these organizations, and my sense is that they'll be the last one to fall into line, because they are heavily funded, supported by the people who are winning with the current system.
I'm not as optimistic about CMS in its current state about making that, but so you were the one that pointed out to me over a year ago that the director of your pain program, your fellowship, said to you at some point, all of you are going to have to look for another job, because the idea of the proceduralist doing procedure after procedure is eventually not going to be the current paradigm. How about those pain fellowships, those academic centers? Are they going through the transformation that we're talking about here, or is this being perpetuated, ad infinitum?
To some extent, they're kind of at least taking the baby steps towards formulating a multidisciplinary program and so on and so forth. But having run what I thought was a pretty good multidisciplinary program, because we had the outcomes to show for it, there are plenty of people who claim to be it. Doesn't mean that it is it, right? So the standardization of, or kind of even putting forth reasonable competencies for the trainees is just started to occur. And this was a conversation that happened in 2007. So a decade later is when it's actually being implemented. But at least, so when people go out after their training process, when they see people with a diverse background, with different approaches, slowly I can sense that, people are acknowledging that this is more than our current pain problem is more than an injection deficit issue. And it's much more wider, and that you have to address all of these issues. I mean, trauma is the most essential issue that we have to deal with. And if, like I said in my conversation yesterday, if we don't deal with it with this generation, we are creating the same thing through the same conduit for the next one, and then the next one, and then the next one, and we will continue to keep paying for the same, we'll repeat the mistake.
And I would just add, and this may be a little too controversial, but there's at least one group that believes that government that payers and even that professional societies will not be successful in solving this, and they've decided to entirely sidestep it. And we don't know if they'll be effective, but with this Amazon partnership, there is this view that they're simply going to marginalize existing structures and disrupt it. It's a little played out, but disrupt it like Uber in a sense. So yeah.
So I was just going to add to your question about fellowships. I've been out of the fellowship director business since 2002, so I'm not plugged in on that end. But a lot of Payne fellows, graduating Payne fellows, wanted to work in Tucson. So I would interview about one a month, so 10 a year maybe for the last 10 years. And I would always ask them, so what's your approach to trauma? And unfortunately, I didn't have anyone answer that question yet.
And we had the physiatrist yesterday, my friend, the race car driver. We talked last night about this, and to him, this was a hugely eye-opening thing. He's a physiatrist. He's been treating pain for his entire 30-year career. Never thought about trauma before. So he came away from this with a big learn. Yeah.
Yeah, I'm surprised that the answer you got wasn't, well, it depends on, was it a car accident or a motorcycle accident?
Yeah.
Because, I mean, yeah, multimodal injury, yeah.
I pretty much spend my day teaching in a pain medicine fellowship. And what I can say is that there's been a growing evolution to understand all these aspects, but it's not to have a moratorium and say all procedures are to go by the wayside, right?
No.
It's to suggest we consider ourselves conscientious injectionists. So the point is to actually have a sense of being prudent, judicious, whether it be with opioid prescribing. It doesn't mean that there's a moratorium on opioid therapy either, but it means that there has to be a very cautious approach in how we employ all of these, a thoughtful, sophisticated approach. That's been lacking. So I think, I don't think that it's kind of like e-learning where the brick and mortar institutions are going to fall apart and everyone's going to be learning in their pajamas at home, and there isn't going to be any institutions. I think institutions will be there, but they're there to serve as an anchor, as an example. And unfortunately, it's been slow to come, but we're there.
Absolutely. So I wanted to ask your opinion about this, which was passed out here. And as I looked through this, I almost passed out because it's just dense reading that I don't think very many people are going to open up and read this all the way through, and it's going to change their lives. But that's the way government agencies think that's how they change things. So this has been a completely different way of doing this by getting a bunch of people together for 2 days and really kind of building that multidisciplinary, cross-talking group, building a new network of excellence, the new neighborhoods, new neighbors, new friends. By the way, did you all know each other when you came in here? Will you stay in contact afterwards? Will you keep propagating this? Because that's my goal with this, man. It's just, you keep doing it, you keep in your own backyard, you keep building these networks and reach out to those yoga therapists that you haven't been doing and those EMDR folks and everyone else that you've heard about and build that into your capacity to help to make this happen here. So I'm hoping that happens. But can you think of other ways? So we did the two ends of the spectrum. A book that's so dense that nobody's going to read it, a really interactive two-day event. What other ways can we use to get the word out about how to do this?
So one of the things that I've noticed with the publishing of the CDC guidelines is in my area, it's sort of become an excuse to quote unquote not treat pain, and which really means they're just not going to prescribe medications anymore, which goes back to what I said before about the treatment of pain equals the prescribing of a pain pill. And it's conferences like this and discussions like this and breaking down some of these silos which will allow and give physicians and other caregivers, healthcare providers, the tools they need to treat pain and not worry about the prescribing of medications, because that's the unfortunate part about it that I've seen. And so in my clinical side, in my pain clinic, I get referrals all the time. Dr. So-and-so isn't treating my pain anymore. And really they just stop prescribing the Oxycontin or oxycodone or whatever. And clearly the patient has lots of trauma, significant behavioral health needs, which were never addressed. Hopefully it's conferences like this and discussions like this that can help providers to get those tools.
I would just add that I think that just as professionals, we've failed to distill this. So, you know, if a stroke is a brain attack, I mean, people are starting to see ways of simplifying and understanding complex concepts. And I was participated on a panel to try to define chronic pain for Academy of Integrative Pain Management, I think last month or something, and the end definition, which was great, but it's like, you know, 70 words or some really, and so we don't know how to explain what is chronic pain. We don't know how to explain that. We can't explain it in a way that passes a grandmother test, that goes in the elevator pitch. We have to distill it.
To that point, the nomenclature, I think, is confusing in a way because we train people to be at level 1 trauma centers. Those guys are dealing with the car wrecks, the plane crashes, all the big disasters. In a medicalized setting, you talk about trauma, and it's the surgical approach to trauma, the acute event that happened. And we're using trauma in a completely different way of describing something. And I'm wondering if people are going to continue to be confused or not understand this unless we come up with some new nomenclature about what we're talking about.
Well, I think to that point is we have to recognize that this is not a doctor-centric fix. And I mean, while I enjoy my colleagues, this is disheartening. It's a bunch of white dudes, you know, and so I mean, but to speak to that, there's no women, there's no community health workers, there's no people from inner city and things like this. But I think at the end of the day that when this conversation is going to actually turn into action and change is when it's a really inclusive conversation and we have a ubiquitous vernacular across all of those sections. And that people can trust again, because I will tell you, and someone who walks into a community of Camden and tries to treat patients there who look at me and say, you have no earthly idea what I'm thinking. My answer is absolutely I don't. I have to figure that out. They have no trust of the medical system, none. And they have no reason to trust us because we have failed them and killed them for years. So we just need to be okay with that and recognize that this is not an us fix. We should be a part of the fix because we were a part of the problem, but at the same time, we need to fall on the sword a little bit and hand off, I think, a lot of this, which is hard for those of us who spend a lot of time training and realizing that there are different versions of training, and wisdom sometimes is better than the book knowledge that we have gained, and that's hard.
So I think that's well, I was just going to say that's the advantage of doing something like ECHO is because in our ECHO, your ECHO, we involve not just physicians, it's nurses, it's community health workers, it's behavioral health coaches, consultants. We even have administrators, secretaries, receptionists, people who do the scheduling who are involved and understand that the continuum of pain care starts at the moment that an appointment is made all the way through the appointment till when the next appointment is made, to those phone calls back and forth, and ECHO can kind of help do that interaction, kind of make it not so doctor-centric.
Great. Jean.
So I'm Dr. Jean Shadatpuri. I work at HealthNet California, which is pretty much the Superior Health Plan equivalent in California, and we are also Centene owned. So thanks, Dan. This was very, very good conference put together. And a very different way to look at how to treat pain. And thank you to all the experts. I want to focus a little bit on the next steps. So, in the last 2 days, we know that doctors, pharma started this problem. There were very low barriers to entry, so this problem snowballed into an avalanche. And the treatment is not easy. It's not the same doctor who can fix this and reverse everything. We also agree that each of you have programs that have evidence-based treatment protocols and have showed brilliant outcomes. So as a payer, and Dan and us will have to figure this out, that if we had to get our members who were suffering, get access to 8 plus 9 of this support system, how would we make sure that we pay for something like this, right? And so, so I'm thinking it would be a lot from our end to figure out what is needed and maybe come up with a menu of services that would be covered in something of like a bundled payment. And California is a little more advanced, so it would be easier for us to think of a bundled payment. But also, I think I would urge each of you to extend your scope of work and your communication to include each of these facets, including, the peer. I mean, this is the first time I heard of this, and I think it's actually something that could work as feet on the ground, easily accessible community. We have community workers and promodoras in California, but I think somebody who's been through that would just relate at a very different level. So I would like to hear from you. How would you extend your scope of what you do? And Omar, you're doing this, a lot of it in CATASYS, and Weizmann Institute is linking a lot of these pieces together. But how would you, in your mind, extend what you do to get that other piece included so that we can figure out one way to pay for all the services?
Well, for myself, being in private practice and having an integrated program, one of the first things is to start to reach out to payers and say, hey, look, this is what we're doing in our private practice, and how can we work together in order to create a model that addresses the issues that aren't currently paid for but can deliver the outcomes and the value that you need. And then the next part is locating people nearby. I mean, this conference is great in communicating with people. Scalability, and I think Omar was talking about it, a key of all of this is scalability. How do we take it from our unique little areas and create a model that one can scale, that does have that integrated level of service? And I think there's a lot of different payment models that are coming out and working on it. I know we've had some conversations with Menu as well in terms of how would it actually look. And I think that those are the first starts to having those conversations, and a willingness on everyone's side to make the connections to say, hey, this would be really helpful. How can that fit in a bigger picture?
I was just going to add to the comment is that one of the biggest issues which the panel has addressed is the knowledge gap of just what is the education needed to train. And the thing about pain is that it's pretty much what everyone's talked about. It's ubiquitous. It's part of every discipline, whether it presents in the emergency room or, I think that Institute of Medicine report was really poignant when it said it's the #1 reason people go to their doctor, but it's the least studied phenomenon at the NIH when it comes to any of the new drug development, any of the thought processes that we've talked about here. So I think in the end, the suggestion is how to level the playing field to understand a new standard of care, and that comes from a broad scope of educating first, in my perspective, and that's similar to the over-reliance on opioid therapy. And that might come from a national perspective. So it's lobbying with large groups like yourself from the state level, then providing programs like this so that everyone in the union can benefit from it nationally.
I got one.
Just one last thought about, in reference to your question, I don't think we have much of a need, I don't think we have any need to lobby payers or convince primary care providers or other providers that diabetes requires a podiatrist, requires a dentist, that CDEs have an important role, and that it's a multidisciplinary team-based approach to manage diabetes. And I think we know that lipids need to be controlled and blood pressure and all the different components. And why is that? I think because diabetes care has been something that we're heavily educated and exposed to. It's taught in residencies. It's emphasized. It's one of the major conditions that we treat in primary care and across disciplines. I think I still believe that the fundamental problem we have with pain is exactly as we've been discussing. Much of what we've talked about and presented as the obvious solutions for how to manage pain in a multidisciplinary way, that's not known. But there was even, as you mentioned, somebody here who didn't know trauma and didn't understand the importance of trauma as contributing to chronic pain. So I think we have a major educational deficit across disciplines, and also my focus in primary care, that's only now just starting to get out. So I think education is absolutely at the core. We have to educate our payers, we have to educate our providers, we have to uneducate and re-educate all of us who were trained that pain is treated with a pill.
Kimber?
Yeah, I'm gonna stand up because I get passionate. I have several thoughts, but I'll try to be as brief as possible. I'm gonna put my peer recovery support hat off to the side for a second and just say, do you want to say something?
You're going to get the last word.
No, maybe, but it's a good one. Put my peer recovery support hat aside first and say that I have a consumer advocacy organization, and I am more in line with maybe being an activist. And some of my roles is looking at the opioid deaths of my friends and the substance use disorder death of my friends and our community, and saying, what the hell is happening? Stop. Right now. So when I got invited to come to this conference, you can imagine what my colleagues had to say about it, right? You're going to sit at the same table and at the same panel with the very people who prescribe the drugs that are killing our friends. That's what I have to deal with on a regular basis. So this is a challenge for us, and I'm so grateful, Dr. Dan Crow, and all of you who've been here, who I have seen nothing but collaborative spirit, taking ownership and responsibility for what we have done well, what we've not done well, and looking at real solutions to what we can do moving forward. I do not believe that we should swing the pendulum so far with our advocacy efforts or activist efforts that opioids can't be prescribed, or that we should just overprescribe medication-assisted therapy without appropriate other interventions in combination with those. But we cannot forget the fact that we have to be responsible. Laziness in prescribing opioids, which we know are highly addictive, and I'm actively working with litigators taking pharma to town, it will not be tolerated. So, not only can we create opportunities like this, right, and spread the word as far and wide, because it's really the only way we're going to get to a really good solution, but we have to use our voices and we have to take responsibility. We just have to. I'm an advocate, and I would say that anyone in this room who's here for the same reasons that says we can't keep doing this, we have to do something different, talk to your policymakers every week if you have to. Start getting loud and proud about the fact that you're doing something different. I'm going to finish because I just get so excited about this, but I just want to say thank you. Thank you to you all as a person in recovery, as an activist who's involved in the National Recovery Advocacy Movement. I will take this message to my colleagues and say there is a way for us to play in the same sandbox together. And I think this has been a perfect example of how this is done. And thank you so much.
Hey, thank you. Thank you. What a great way to close it. Thank you, Kimber. We gotta shut down. I'm sorry, but.
Thank you.
Chris Shada with the Texas Pain Society, and you asked when things are going to change. In Texas, it will be in 2019 because of reactionary legislation. Now, to the House of Medicine's benefit, and I invite all of you, everyone, to get involved, because there's a joint committee meeting with the Senate and the House having open hearings on this topic, all right? And we're fortunate to have a senator doctor and a House doctor chairing this committee. So, the time is now in Texas, and I challenge you and I challenge all of you to get involved in this process, because they are going to do something to us. It can be good, it can be bad.
Thank you. So the word is we are supposed to become activists too. So Kimber, yeah, I like that. I hope you all had a chance to really develop a new set of friends and neighbors, figured out how to keep these connections going. I hope you all learned a lot during this, and I hope you all are leaving with a completely different concept of how chronic pain and substance use manifest itself and where we need to go in the future. So with that, I want to thank all of you, everyone that came here, everyone that was a participant, everyone that spoke, and I want to especially thank people like Adele and Katie and Stacy and Irissa and Brittany and everyone else that made this whole thing happen. So thank you. Safe travels, and stay in touch.
Thanks a lot, Dan. That was wonderful. Yeah, we'll be in touch.
We got you out in time.
Yeah.